Okay, this talk is about deep venous thrombosis and its evaluation. Even though this is not the favored study of most sonographers or radiologists, it is important because prompt diagnosis of thromboembolic disease is critical, as it may lead to acute pulmonary embolism. Pulmonary embolism can occur in up to 50% of cases of untreated DVT, and as such, it is the most common reason to order lower extremity duplex studies. As I mentioned earlier, ultrasound is the initial diagnostic test of choice, and with ultrasound we can visualize complete or partial occlusion. We can localize the thrombus. We can identify whether it is loosely attached or free-floating. We can also follow progression of thrombus, let's say with treatment. And it is also useful in determining the age of the thrombus, whether it is acute or whether there are chronic changes in the vessel. So the objective of the examination is, first of all, to exclude thrombosis. And as I mentioned earlier, we want to determine the location, whether it is attached or unattached, partial or complete, and based on its appearance, whether it is acute or chronic. The indications for the study: patients may present with suspected pulmonary embolism, or they may present with more local symptoms such as leg pain, swelling, and erythema, the presence of a palpable cord. They may present for follow-up to see if the thrombus is responding to therapy. They may order the study pre or post surgery, or in patients with high risk for deep venous thrombosis. The risk factors include any patient who presents with Virchow's triad, which includes venous stasis, endothelial damage, or hypercoagulability. These include patients who've experienced trauma or surgery, which is a type of trauma, malignancy, patients on oral contraceptives, pregnant patients due to stasis in the lower extremities, patients with liver failure who are hypercoagulable, or patients with a history of prior DVT. The point of this slide is to demonstrate the more central anatomy. The common iliac vein, I'd like to point out, is medial and posterior to the artery. And you can see that the left vein is compressed by the right artery, which leads to increased risk of DVT on the left. Okay, I just want to point out the anatomy here. The vessels that we study include the common femoral vein, the femoral vein, which is formed here after the confluence of the deep femoral vein, which is right here. We have the greater saphenous vein, which is actually superficial. Its more central portion is a part of the examination. And coming down, this whiteout area is the vein as it's passing through the adductor canal. And then we see here the popliteal vein. This is the sonographic appearance. A few things I wanted to point out. These images are obtained in a transverse plane, and if you see here, the vein is always slightly larger than the artery. At the level of the common femoral vein, the vein and the artery lie side by side. As we come down to the femoral vein, the vein and the artery are on top of each other. And as we move posteriorly to the popliteal vein, we can again see that the vein is slightly larger than the artery. Some landmarks. Some people refer to this as the Mickey Mouse view. This is also obtained in the transverse plane. We have the common femoral vein, the greater saphenous vein, the common femoral artery, and deep femoral artery. In the long axis, we also look at the deep femoral vein as it's joining with the femoral vein to form the common femoral vein. This is an image obtained from Netter demonstrating the adductor canal. The adductor canal is formed where the sartorius, which is this cut muscle, crosses over the adductor longus, right here, and the vastus medialis. The importance of the adductor canal is this is an area where the vein and artery dive deep into the thigh and may be more difficult to image and more difficult to compress. You can eliminate this problem by supporting the thigh posteriorly with your hand and compressing from anterior with the transducer. And in transverse, you can see here, this is the femoral vein and the artery as it's traversing the adductor canal. It's deeper in location, and then here is a compression view with just the artery showing. The superficial veins are not paired with arteries, and you can see here there is a long axis view of the right greater saphenous vein, and more centrally you can see that the greater saphenous vein joins with the common femoral vein. This is the location where we obtain our image. One other thing to point out, sometimes you may see echogenic linear structures projecting into the lumen of the vein. These are the valves, and these are good locations to look for thrombus, as thrombus tends to form here first. Some variants to be aware about. 25 to 35% of popliteal veins are duplicated or bifid. Others believe that this may be related to a high bifurcation of the posterior tibial and perineal trunks. 20 to 40% of femoral veins are also duplicated. One clue may be that the vein, which is normally larger than the artery, may look slightly smaller, and then when you see this, this should prompt a search for a second vein or a duplicated vein. This is also a potential pitfall when evaluating for deep venous thrombosis, because if you see one patent vein, you may miss the second duplicated vein that is thrombosed. So it's very important to be aware of this variant. Okay, our protocol involves imaging the common femoral vein, the saphenofemoral junction, which is where the greater saphenous vein joins the common femoral vein, the femoral vein, which we image all the way down into the popliteal vein. We also look at the proximal portion of the deep femoral vein as it's joining with the femoral vein. Obviously, we would like to evaluate anything that appears abnormal, any ancillary findings in the lower extremity. There is a controversy, or at least differences, in the way institutions perform the study. Some may perform unilateral studies, some may do bilateral, and there's a large variability in whether the calf is included in this study. At Georgetown University, we currently routinely perform imaging of the calf veins, which include the perineal and posterior tibial veins, with every study. Okay, the patients may be scanned supine or standing or sitting up. We can have their legs dangling over the edge of the stretcher, and we usually position their legs in a semi-frog leg position. A 5 to 8 megahertz can be used, a linear array, for femoral duplex study, and we may switch to a higher frequency transducer for the saphenous, since it is more superficial. We may also switch to lower frequencies for deeper structures, such as the iliac vein or the vena cava if necessary, or in larger patients. In this case, a 4 megahertz or a curved or sector array can be used. For grayscale, we use for transverse compression, and then we can switch to color Doppler to detect non-visible plaque. It's also good when compression could not be performed or for finding deeper vessels. Okay, now this is a cine loop of transverse compression. It is the most important part of the examination. I'm going to play it again. Okay, now the vessel that is completely coapting is the vein. We see the artery is on top. And it's very important to apply pressure enough to coapt the vein or to make sure that the vein walls come together. The principle of this is if the vein walls completely collapse or come together, then there must not be anything inside the lumen, and therefore you can eliminate or exclude the diagnosis of thrombosis. Compression is performed in the transverse plane because in the long axis, during compression, the transducer may slide off the vein and may simulate complete compression and lead to a false diagnosis. The vein is compressed every 1 centimeter all the way down the leg, from the common femoral vein down to the popliteal vein. And in some institutions, the calf veins may also be compressed. Also augmented with color and spectral Doppler to confirm the presence or absence of flow. The one caveat is that in the presence of very slow flow, color Doppler may not detect flow. It can also document the most proximal extent of thrombus. It may be used in identifying smaller veins or confirming blood flow when compression cannot be performed. Okay, we're going to move on to the criteria for a normal study. A normal vein is completely compressible. It has a thin and very smooth wall, almost imperceptible, and an anechoic lumen. The one exception to this, of course, is with very slow flow. The lumen may appear hypoechoic or may have some internal echoes. Walls will not coap when the lumen contains thrombus. And remember again, compression should be performed in the transverse plane, such as in this image. Here we have a non-compression image with a vein slightly larger than the artery, and then just the artery showing as the vein walls have completely coapted. Okay, the normal criteria for Doppler. There are 5 important features of blood flow in normal veins. First of all, there should always be spontaneous flow, even with the extremity in dependent position. Blood flow should occur towards the heart, even without muscular compression. Sometimes in small veins, spontaneous flow is difficult to detect due to slow flow. Normal venous flow also changes in response to respiration. This is sometimes termed respirophasic. When absent, the flow is described as continuous. This may indicate the presence of obstruction proximal to the site of Doppler examination. Flow can also cease with Valsalva. Valsalva is deep inspiration followed by bearing down. It can result in cessation of blood flow in large and medium-sized veins. But this documents patency between the Doppler portion and the thorax. Augmentation can be performed by distal compression. With augmentation, an abrupt increase in Doppler frequency shift can be seen after manual compression of the extremity distal to the site of ultrasound examination. An absence of response would indicate a substantial obstruction distal to the site of Doppler examination. Delayed or weak augmentation may indicate distal obstruction that is incomplete or circumvented by collateral vessels. Currently at Georgetown University, we do not include this in our examination as it has not proven reliable for excluding thrombosis. And in the setting of a normal study, augmentation has not proven to provide any additional information. Now, in a normal venous system, blood flows only towards the heart because of the presence of valves. Valves permit retrograde. When they permit retrograde flow, these valves are described as incompetent, and this is a diagnosis when retrograde flow occurs in response to Valsalva or manual compression proximal to the site of ultrasound examination. Okay, so there's a difference in what is evaluated and what images are obtained. We routinely compress every centimeter down the length of the veins being examined. However, we only take representative pictures for documentation. In the transverse plane, we obtain images of the representative images of the common femoral vein. We obtain images of the femoral vein in 3 locations, and some people would like to designate these as proximal, mid, and distal, but we prefer to designate them as central, mid, and peripheral to avoid any confusion between the anatomic naming and some other naming systems. Central would mean closest to the heart, and peripheral would mean farthest away from the heart. We also obtain images of the popliteal vein and transverse, and then in the long axis view, we take representative images of the common femoral vein at the saphenofemoral junction to document the absence of thrombus in the greater saphenous vein near its confluence. Again, we obtain images of the femoral vein, the popliteal vein and long axis, and also the confluence of the common femoral vein with the deep femoral vein. Again, if there's anything abnormal, obviously we would like to document that with images as well. Okay, an abnormal study, let's talk about that. Non-compressibility of the vein is the most important criteria for establishing the diagnosis of thrombosis. If the vein does not compress, there is something in the lumen. Usually the vein is somewhat larger than a corresponding artery, but if it is even larger than that, then a thrombus should be suspected. And sometimes this may be the only sign of thrombosis on grayscale. You can see here there is a little bit of thrombus shown, but you do see that the vein is somewhat larger or substantially larger than the artery, and thrombus is suspected. In addition, in the image on the right, you can see that there is non-compression of the vein, also indicating the presence of thrombus. Free-floating or partially attached thrombus may also be seen on grayscale, but normally that is much easier to detect either in the long axis view or with color Doppler. And here's an example of that. In the long axis view, you can actually see that a large portion of the thrombus is actually not attached to the vessel wall. This is sometimes called free-floating or partially attached thrombus. This is a partially occlusive thrombus and is at a greater risk for detaching and embolizing. On color, it has this appearance. You can see here we have the artery and the vein. The vein is filled with echogenic material. It is not substantially larger than the artery in this image, but you can see that you have the impression that this is completely occluded with thrombus. With color Doppler, you can actually see that there is flow around this, and this was further evaluated centrally. You can see here's the greater saphenous vein coming in. We have a little bit more space around this thrombus, and as you can see here in the iliac veins, this vein is partially attached. We usually prefer our technologists to not compress in this situation because this type of thrombus is associated with a greater risk for detaching and embolizing. Okay, and here is a cine of that thrombus, and as you can see, it does appear to be floating within the vessel. And again, when our technologists see this, they're instructed to not compress the vein. Okay, let's talk about abnormal spectral criteria. As mentioned earlier, there should be respiratory phasicity to the vein. And in this image, you can see a continuous pattern. This may indicate that there is an obstruction central to this or an extrinsically compressing lesion on the central veins. Spectral can also be used to confirm the absence of flow, such as in this case, you can see that the artery is patent on this color Doppler image, but there is thrombus occupying and occluding the associated vein and absence of flow on the spectral image. Okay, now thrombus can be classified as acute. Some classifications will include subacute, though there is a lot of overlap between the acute and subacute phases, and thrombus may persist up to 6 months, and therefore it's difficult to separate these two classifications. Chronic thrombus is actually a misnomer. We prefer to use the term chronic changes in the vessel related to thrombosis. So this may include echogenic material, such as a calcified residual thrombus. The vein may completely occlude and never become patent and result in a fibrous cord. There may be wall thickening, possibly with calcification. The wall thickening may prevent compression. You may see a valve abnormality or a scarred valve, and there can be Doppler flow abnormalities. Going back to the acute Acute thrombus tends to be very low in echogenicity. Again, in the acute setting, the vein is substantially larger than the artery. There is absence of compression or inability to compress the vein. Again, we may see free-floating thrombus. Over time, as thrombus ages, echogenicity will increase slightly, but the intensity of the echoes remain low. Over time, the vein lumen may decrease in diameter, and this is in the subacute setting. Thrombus will no longer be free-floating, but become adherent to the vein. Recanalization may be occurring, and collateral veins may be seen. The one misnomer or misconception is that collateral veins take time to develop, and that is actually not true. Collateral veins can be seen often immediately after acute thrombosis. In the subacute setting, collateral veins may continue to enlarge. And in the chronic setting, if the vein remains completely thrombosed and becomes or completely occluded and becomes a fibrous cord, one pitfall is to avoid mistaking a large collateral vessel for a native vein. Usually a collateral vessel will have an abnormal Doppler pattern, spectral pattern. Okay, here are some examples. We have here in the transverse compression views, the right common femoral vein, which is substantially larger than the associated artery. We see a little bit of material within the vein, but you can see that there is more than what is present on or what is visible on the non-compression view, limiting compression of the vein. In the long axis view, you can see that there is expansion of the vein compared to its normal diameter, and in the acute setting, a collateral vein has already formed. Spectral Doppler here will confirm that there is absence of flow, which is also not detected on the color Doppler. Okay, an example of chronic change, you can see here the vein is the same size or smaller than the accompanying artery. The vein wall is echogenic and thickened, and compression is not easily obtained. Other findings that may be seen: calcifications, webbing, which I will show in a second, or there may just be an echogenic sclerotic cord. Here's an example of webbing or synechia. They may present as fine linear structures within the lumen of the vein. The difference between this and a valve is that synechia may traverse the entire lumen of the vein or may extend for longer distances than a typical valve. As mentioned earlier, collateral formation, which may occur early, can be seen, and these should not be mistaken for patent veins when they are larger. Here we see smaller collateral veins in the presence of a thrombosed common femoral vein. And here are more examples with collateral vessels around a thrombosed vein. And again, there is continuous flow present in this collateral vein, which should not be confused with a partially occluded femoral vein. Okay, moving on to ancillary findings. Sometimes a patient may present with lower extremity symptoms and not have deep venous thrombosis, though you may find other reasons for the patient's symptomatology. One of the most common findings, ancillary findings in a lower extremity examination, is a Baker cyst. And there is a jerk reaction when people see a cyst in the popliteal fossa. They tend to call these Baker cysts automatically. But the one caveat is that in a small proportion of these patients, synovial sarcomas may present with the same appearance as a Baker cyst. So we prefer to image what we think are Baker cysts with the three landmarks present. Now, Baker cyst is nothing but distension of the gastrocnemius semimembranosus bursa. And in order to prove that you are in that bursa, you want to demonstrate the medial head of the gastrocnemius and the semimembranosus tendon, and you want to show that the fluid is coming from between these two structures and extending into the cystic structure. And here we have the back of the tibia. So without those landmarks, you don't know what you're looking at. It may be that the patient is post-op and you weren't informed of this information, and you may be looking at a seroma or a resolving hematoma. And again, in a very small population, you may be looking at a synovial sarcoma. So I think it would be very important that you're very strict about showing the landmarks to prove that you are looking at a bigger cyst. In the long axis view here, you can see that the cyst has rounded margins, so you know it's under tension, and in this case, it's likely intact. But in this case, you can see that the inferior border is pointed, and you can see fluid tracking in between the fascial planes of the calf. This indicates that this cyst is likely ruptured, and this commonly presents with symptoms that mimic or at least can be confused with deep venous thrombosis or calf thrombosis. Edema is a very common finding also. You may see interdigitating black lines or anechoic lines, which is fluid within fascial planes of the subcutaneous tissues. Oftentimes, all you may see is just echogenic appearance to the subcutaneous fat, which is normally dark when there is no edema present. Fluid collections, which look very similar to popliteal cysts, can present in the popliteal fossa after surgery, but can also present in the proximal extremity when there is trauma or recent injections, or in this case, a rupture of the quadriceps muscle. And you can see here a collection with some complexity because this actually represents a hematoma. Lymph nodes are commonly found in the groin, and when they are ovoid or kidney bean in shaped, when there is an intact fatty hilum, or you may see one vascular pedicle, they are considered normal, even when they appear large. An abnormal lymph node, on the other hand, becomes rounded. It may become more hypoechoic. It will lose its fatty hilum, and when Doppler is performed, you can see that there is more flow than just a simple vascular pedicle. Aneurysms can sometimes be incidentally found. Here we have an example of a right common femoral artery aneurysm. The vein is here next to the artery, but you can see that the artery is much larger than the vein, and there is plaque along the periphery of this artery. In long axis, you can see that there is fusiform dilatation of this vessel. This is something that we more recently recognized as a common occurrence, or at least a common presentation for patients presenting for a DVT study in our department. Here we have an image, and just to orient you, this is imaging from behind. This is the proximal calf, and we have the medial gastrocnemius fibers present here, which are terminating abruptly here. And then we have a complex fluid collection representing a hematoma. On this panoramic view, we again see this is the medial head of the gastrocnemius, which is interrupted with a large hematoma in that area of interruption. And deep to this is the soleus muscle. This represents a tear of the medial head of the gastrocnemius, which is actually not that uncommon and can present with calf pain, obviously, and present to the department for a DVT study. Another diagnosis that can present with very similar symptoms and in a similar location is a rupture of the plantaris tendon. So on this image, I'd like to point out this is the plantaris tendon, which is seen medially. Distally, it will join and reside in the medial edge of the Achilles tendon. Okay, and it runs in between the soleus muscle and the gastrocnemius muscle. These patients can present with an elongated fluid collection which tracks between the gastrocnemius and the soleus muscle. And you can see here on this panoramic view the fluid collection tracking again in between the gastrocnemius and the soleus and a free edge of the plantaris tendon distally. This is a plantaris tendon rupture. This patient also had a medial gastrocnemius tear, as you can see here, which can occur in conjunction with the plantaris, but the major pathology that's present in this patient is the plantaris tendon rupture. These two entities are not that uncommon. They can present, and often with a very acute history. Okay, one other finding here, patient with lower extremity edema. no DVT, but as the vein was being imaged, you can see that there is an arterialized flow pattern in the vein, which prompted imaging of the associated popliteal artery. This is not the normal appearance to a lower extremity arterial waveform. This is actually decreased in resistance, and the conjunction of these two findings is most compatible with an arteriovenous fistula. Sometimes the fistula may not be seen, but this high arterialized flow in the vein is enough to make the diagnosis. This doesn't occur very often, but this patient did present with lower extremity pain. No deep venous thrombosis was found. However, there is a mass in the tibia, which is invading the cortex and is within the marrow. There's a lot of vascularity to this mass, and this was a Ewing sarcoma diagnosed during a lower extremity study. One other thing commonly presenting in patients with groin pain who come to our department to evaluate for common femoral vein thrombosis is iliopsoas bursitis. And here we can see a compression view. We have the artery in the vein completely collapsed, but there is an extra structure, which is actually a fluid collection. And you can see again here, we have the artery in the vein, and then we have a fluid collection deep to the common femoral vessels. And you can see it here on this CT scan, again, artery and vein, and the fluid collection. This is iliopsoas bursitis. Oftentimes you may see a cystic structure in the popliteal fossa, and it may be called a Baker cyst. In this case, the cyst contained several calcified or ossified bodies residing within the cyst. And this is a presentation of synovial osteochondromatosis, which is confirmed here on this lateral plane radiograph of the knee. Okay, so this can be tricky in examination. We can see here on a color Doppler view of the external iliac vein, there is flow in the artery, but no flow in the vein. So as I mentioned earlier, compression is actually the most important part of the study. And you can see here, during compression, the vein completely collapsed. So this is one of the pitfalls when evaluating for thrombosis. Color can sometimes simulate the absence of flow, but really what is happening is there's very slow flow. And in this same patient, you can see that there is no flow detected on color, but there is very slow flow detected on the spectral Doppler. Here we have it again. And this is the same pattern demonstrated all the way down the extremity. But when we augment, there is suggestion that there is no obstruction. So when you see this loss of phasicity or a continuous waveform, very slow flow, what you need to do is look for a central obstructing process or a central extrinsically compressing process. And in this patient who presented with these findings bilaterally, there are bilateral lymphoceles which are compressing the veins in this patient who had surgery for prostate cancer. Okay, so just going back to some of the pitfalls again, just what we just saw is slow flow may mimic absence of flow on the color Doppler images. I talked about earlier compression difficulties with thickened veins or veins with chronic changes from prior thrombosis, a mistaken identity of a collateral vessel or a superficial vein may give a false negative diagnosis. In the setting of a duplicated system, the presence of one patent vein may result in a negative study with non-identification of the paired thrombosed vein. Chronic changes should not be called chronic thrombus, mainly because referring physicians may see the word thrombus and start treatment. Recurrent DVT can sometimes be difficult because there will be chronic changes with superimposed acute changes, and poor venous distension and reduced flow may also result in a false diagnosis. Here's an example of acute and chronic. You can see that the vein is much larger than the artery. It is distended, it does not compress, and there is some hypoechoic material within the vessel lumen. But in addition, the vein walls are thickened, limiting compression somewhat and are echogenic. So this is a patient with chronic changes from prior thrombosis who also acutely thrombosed. I mentioned before that the normal criteria for vein is an anechoic lumen, but in this case there are echoes within this vein. Simulating the presence of thrombus, on the compression view you can see that the vein wall is completely coagulant, which excludes the diagnosis of thrombosis. This increased echogenicity is related to rouleau formation and again can be seen with slow flow. Okay, and lastly, just want to point out some limitations to the examination. Patients with open wounds may sometimes not be open to you compressing their leg, and obviously we don't like to do that. When they have dressings, we may remove dressings, but there are a few complicated surgical dressings that we need to leave alone, and we may sometimes not be able to evaluate vessels that are deep to these dressings. Larger patients are obviously difficult to examine and can also be difficult to examine due to either their size or due to severe edema. It may necessitate switching to a lower frequency transducer. If there's calcification in the adjacent artery from atherosclerotic disease, it may limit compression of the adjacent vein. And again, patients who are recently post-operative may not be positioned properly for the examination, and we may sometimes have to rely on the color and spectral Doppler to aid in the diagnosis of deep venous thrombosis.